Morning, everyone. I'm Dr. Ashish Agarwal, and today we are having a CGR from the Department of Gastroenterology. We are talking about an endoscopic innovation in GERD, that is a treatment beyond acid suppression. We all know that GERD is very common, and a lot of patients have this problem intermittently and persist, and some people do have persistently in spite of taking treatment. The most commonly used treatment for the disease is PPI, which is often taken off label, and some of the patients do require to take it repeat prolonged PPI, and they have recurrence of symptoms when they stop PPI. Sometimes even bothersome symptom leading to decrease in the quality of life. So these patients, then with the options that we have are the surgical and endoscopic. Surgical techniques, the most common being nascent fundoplication. And nowadays, there's a growing interest in minimally invasive procedures. So we have a lot of endoscopic procedures that have come up. Majority of the endoscopic procedures are tech invasive. A lot of tech is needed and a lot of instruments are needed. So we'll be talking about one of such innovative endoscopic procedure which we have recently started in our department and have completed a small study regarding the same. The procedure is called as PEC-B, and it's a very simple, very cheap, very easy to do procedure in patients with GRD. So I would call Dr. Ankit Agarwal, who's assistant professor in our department, who will first give you a brief review about the management options for patients with GRD.
Good morning, everyone. So today we'll discuss about a disease which is very fairly common. Each one of us has seen it. So now we'll talk about how endoscopic advancements has changed the treatment paradigm in 2025. So gastroesophageal reflux, as we know it, is the reflux of stomach contents into the esophagus. However, when it causes troublesome symptoms in form of persistent heartburn or persistent regurgitation, it is called as gastroesophageal reflux disease. Becomes important because it is a significant health concern. And this was a study which was published in Indian Journal of Gastroenterology in 2011, and it showed that up to 20% of patients have GERD, which is comparable to Western population. So this becomes important in our context too. So we'll discuss about the management options, the pathophysiology, and we'll look how we managed a patient of refractory GERD who presented to our clinic. So a 29-year-old lady, she presented to us with persistent symptoms of heartburn and regurgitation, and she was on PPI for past 1.5 years. Initially, she was on pantoprazole. She was taking it daily for 1 year. Now somebody switched it to rabeprazole, and she was taking it twice daily for last 6 months. And from outside, when she was referred to us, she was told to continue rabeprazole for 6 months more, and then some other intervention was advised for her. So she came to us, and the first question when such patient comes to our clinic is whether this is really is GERD or not, whether this patient really has gastroesophageal reflux disease or not. Number one. Number two is, if she really has gastroesophageal reflux disease, what do? We change the PPIs because there are many flavors of PPI that are available in market. Do we add H2 receptor antagonists, which are mainstay before arrival of PPI in the market? Should we label her as a functional case of functional heartburn, which is fairly common, and we start her on some sorts of antidepressants like tricyclics or SSRIs, or we refer her for surgery? So the most important point when such a patient comes to our clinic is we test her whether the patient has actually reflux disease or not. So we did an upper GI for this patient. So as you can appreciate in this upper GI, and this is the lower esophageal sphincter. So as we can see, this is the esophagogastric junction. There are some erosions at the esophagogastric junction. You can see some erosions here, some erosions here. So this patient falls under the realm of erosive esophagitis. Now we can appreciate that this is a fairly unhealthy looking lower esophageal sphincter when we compare it to a normal looking lower esophageal sphincter. So as we can compare from the image on the right, so this image looks like this patient has some sort of gastroesophageal reflux disease. So now this patient fulfills all the criteria for having refractory GERD, which are described as patient who fail to obtain a satisfactory symptomatic response or complete esophageal healing after full course of a standard dose PPI. Some people gives twice daily PPI. Some people are fairly okay with daily single dose daily PPI. However, if it does not resolve over 8 weeks, then then the patient falls under the category of a refractory GERD. So with this context, 3 questions came to our mind when this patient presented to our OPD. Should we continue PPI? Now we can all agree that this patient is already on PPI for past 1.5 years. Giving more PPIs will not help her. The second question that came to our mind is whether we refer the patient for surgery or should we consider this patient for endoscopic management of GERD. So before going to the endoscopic management and the surgery part, we'll just discuss the pathophysiology of GERD. Our understanding of GERD has changed. So initially, what was basically the pathophysiology of GERD was increased acid production. Now it has changed to a dysfunction of lower esophageal sphincter. So this lower esophageal sphincter is a complex structure, and when we look at the myoarchitecture of lower esophageal sphincter, from inside to outside, we have mucosa, we have submucosa, and then we have the circular muscle. This circular muscle at the lower esophagus, these hypertrophies and forms the lower esophageal sphincter. Also, this circular muscle divides into 2 types of fiber. One is the clasp fibers, and second, the sling fibers. So what these clasp fibers do is they wrap itself around the lower esophagus and causing its constriction. And what the sling fibers is, it shortens the esophagus. So what happens is, in a state of relaxation, this fundus, this area is in state of tonic contraction, and it causes the LES to remain closed when the patient is relaxed. The second thing which helps prevent reflux is the presence of diaphragm. So this is the esophagus. So some portion of esophagus is intra-abdominal. Esophagus is not completely a thoracic organ. Some portion is intra-abdominal. What happens is it is covered outside with the diaphragm effect, which is called as pinch-cock effect, and the diaphragm constricts the esophagus at that point, helps in preventing the reflux. And the third thing is the angle of His, which is a unique thing to lower esophageal sphincter, and it is an angle which is the angle where the greater curvature meets the lower end of esophagus. So it provides some sort of unique pathophysiology to the lower esophageal sphincter that we'll discuss. So when we look at the lower esophageal sphincter from the stomach, so we have to retrovert our spoke. So consider yourself that you are standing in the pylorus, and then you are looking at the lower esophageal sphincter. So this area is the greater curvature and the fundus. This area is the lesser curvature, and this area is the angle of His that we had talked about. So what happens is when patient eats too much food, or when we eat too much food, so this fundus starts distending, and what happens is start putting pressure on this angle of His, and it causes it makes it as a functional wall, and it closes itself against the lower esophageal sphincter. So the sanctity of this lower esophageal sphincter is maintained by this angle of His, which is unique to this sphincter in the entire body. And when this property is lost, patient starts having symptoms of reflux and symptoms of regurgitation, which cannot be managed by PPI because PPI will simply decrease the production of acid. However, we have to reconstruct this LES sphincter either by surgery or endoscopy to prevent the symptoms of reflux in these patients. So initial management of GERD dwells on the lifestyle changes like losing weight, stopping smoking because it causes diaphragmatic muscle weakness and everything. PPIs are the mainstay of therapy for GERD. However, considering the side effect profile, because now multiple side effects have been described with PPI, so PPIs are no longer forever acceptable for management of GERD, and we should consider this because all of these patients are generally young. So our index patient is a 29-year-old lady. She's already been taking PPI for past 1.5 years. Should we give her lifelong PPI? So this is a question that we should always think when we are managing a case of refractory GERD. However, the data is immense with PPI, and it heals erosive esophagitis in like 86% patients at 8 weeks. It is better than H2 blockers. However, the problem still remains with long-term adherence. And now multiple adverse events have been described with PPI to the tune that many nephrologists have stopped prescribing PPIs for their patient because it causes acute interstitial nephritis. This is another one of complication of PPI patient on long-term PPI. So this is the fundus of the stomach, as we had previously seen, that these are multiple polyps. Now, these when I tell you that these are benign-looking polyps, neither the patient accepts this nor the treating physician accepts this. These are benign looking polyps and nothing to be done for them. So these are kind of complications which occur in the patient with long term PPI. So we had to resort to other methods for management of refractory GERD in these patients. So our guidelines now recommend that for patients with confirmed GERD, that we have to prove first that patient does not have functional reflux and has confirmed GERD, PPI should be given at a lowest possible dose for shortest possible period, and long-term management options should be discussed with him or her. So the gold standard treatment for management of refractory GERD is the surgical management, in which they do a fundoplication procedure, which is basically they wrap the fundus around the esophagus, and thus augmenting the effect of diaphragm, augmenting the defect of diaphragm and augmenting the Pinchcock effect. So multiple types of fundoplications are, multiple variations and multiple types of fundoplications are done by surgeons, like Nissen's fundoplication, Toupet and Dore. All are basically same. The basic concept around them is same. And this still remains the gold standard. So and the data is abundant. The 20-year follow-up studies are available, which have some studies show 80% success rates with surgical management of GERD. And the important point to be considered in patients with refractory GERD is the surgical management is the only management option which is available for patients with large hiatus hernia. So currently for large hiatus hernia, patient cannot be on long-term PPI, it will not be resolved. There is no endoscopic therapy for large hiatus hernia. So patients with refractory GERD and large hiatus hernia goes for surgery. However, the problem remains the surgery is an invasive procedure and the patient acceptability is poor. So this was an interesting study which was published in 2013, that only about 5% of patients actually undergo laparoscopic fundoplication when they are referred for the surgical management of GERD. So in 2025, the management of GERD has somewhat changed. So patients who are well controlled on PPI, does not have any adverse events, are compliant, does not have any hiatus hernia, continues to get PPI. However, the patient who are not well controlled on PPIs, if they have large hiatus hernia and are willing for surgery, they go for surgery. There is no other option that is available for them. However, the endoscopic therapies are slowly been creeping in this realm, and the patients with small hiatus hernia and the patients who are not well controlled on PPI, we can consider them for endoscopic management. So our patient in this scenario, she refused surgery, as we have already seen that only 5% patient actually undergo surgery. So then we started discussing endoscopic therapies with her. So there are multiple endoscopic therapies, the most important of which are plication-based therapies. What we do is, what surgeon used to do from outside, they wrap the fundus around the esophagus, we do it from the inside with the help of an endoscope. So the most common type of endoscopic management which are available are transoral incision-less fundoplication. There's a radiofrequency probe, so we go into the lower esophageal sphincter, we give some radiofrequency there, and it causes the circular muscle to hypertrophy, and then functionally it improves the augmentation of lower esophageal sphincter. The other plication-based therapy, which is GERD-X, these are the two most commonly used, the transoral incision-less fundoplication and the GERD-X device. And then there are some other endoscopic mucosal therapies. We'll discuss about what endoscopic mucosal therapy and how they actually works. So there are two types. One is anti-reflux mucosal intervention, which comes in two varieties. First is ARMA and second is ARMS. And second, which we did in our patient, is the peroral endoscopic cardial constriction with the help of bands. So it is called as PEC-B. So when we look at GERD, so now we can see this as we had discussed earlier, this is the fundus of the stomach, this is the lesser curvature of the stomach, and now we can see, as if we compare it from the first image that I showed, that this patient, the flap wall effect has lost. So what this device is, this is a special device. What it will try and do is, it will start. So what it will do is, it is a kind of stapler, and it will virtually recreate the lower esophageal sphincter as we had shown earlier. So this is a device, multiple bites are taken. So what I'll show you the end result. So So this is the end result. So as we can see, it has virtually created a lower esophageal sphincter, a flap valve effect. So this is now the lesser curvature, this is now the fundus of the stomach, and it does not have all the complications that are related to surgery that are because of the because when we do surgery, the fundus is wrapped around the esophagus and the capacitance of stomach is decreased. So this problem is not with this device. Similarly, in transoral incisionless fundoplication, a device similar to GERD-X, however, has been propagated by a different company. The basic idea is same. So what we do is now we can appreciate easily. This is the fundus, this is the lesser curvature. What they are trying to do is make the flap valve again. So I'll show you the end result again. So this is the end result of this therapy. And then there is a third therapy which is known as strata, in which there is a radiofrequency probe which hypertrophies the circular muscle. So the problem with all these therapies are their cost. So as you can see, the cost is more than 1 lakh rupees, and there is a good learning curve with them because they have their own set of complications and you need a specialized and dedicated training. So these all criteria or these all things prevented its popularization. Because of high cost, it requires dedicated instruments, it requires specialized training, and then there are specific subsets of patients that we can do these therapies in. So what do we do for this patient? So now we are entering into the era of low cost endoscopic therapies for GERD, in which we do not need a dedicated instrument or a separate device. We can do it with whatever readily accessible available accessories that we have. So in this, what we try to do is we just ablate the mucosa. And when we ablate the mucosa, and we think that this mucosa will heal with fibrosis, causing the constriction of the area. So I'll show you how ARMA is done. So this is a device, this is a snare which is available. We do polypectomy with it. It can be used multiple times, so you do not need a special device to perform this anti-reflux mucosal surgeries. So what happens is, this is, as we can again appreciate, this is the greater curvature, this is the lesser curvature, patient is symptomatic. So what we do is, we ablate this area. So we ablate this area. So when we ablate this area, and we after some time, this area heals with fibrosis, causing the diameter to decrease and causing its constriction, and subsequently improving the symptoms of regurgitation. So what we do is, we start ablating this area. We start ablating this area, and we continue and ablate it. So this is the end result. So this is the end result. So we have virtually ablated the lesser curvature area. Now when it will heal, it will cause the constriction of this area and this prevent the regurgitations. So coming to other anti-reflux mucosal intervention. So the problem with ARMA is it requires long time. It requires at least an hour, number one. Number two, it has some complications in form of perforation. Patient has some symptoms for, like 8 to 12 week patient continues to have symptoms, and it might sometimes require multiple interventions. So we were in a search of a therapy which did not require specialized accessories. So we came across a therapy which required only EVL bands. It was low cost because EVL bands are like 1,500 rupees. It is an outpatient procedure, and the procedure time is just 10 minutes with a very small learning curve of 3 to 5 procedures. And what we actually did in this patient, this procedure is called as PECB, which is also known as per oral endoscopic cardial constriction with the help of EVL bands, which is a very low cost therapy and which subsequently helped our patient. So I'll invite Dr. Ashish Agarwal sir to further talk about PECB and how this therapy helped our patient.
Thank you, Ankit. So Ankit has briefly reviewed most of the available therapies for endoscopic management of GERD, and you have seen that most of the problem with most of the endoscopic therapies for GERD are that they are technology intensive. It's mainly technology dependent, and that is why the market is pushing towards them. Most of the studies that are coming currently on endoscopic therapies for GERD are on GERD-X and TIF, with very few studies on ARMA and ARMI that we have recently discussed. And regarding PECB, this procedure was described around in 2013, but there is no enthusiasm about this technique. It's a very simple study. It's a very simple procedure. It takes 5 to 10 minutes, can be done on outpatient basis. It's done just using EVL bands. A gastroenterologist, the first endoscopic intervention that he does in his life is EVL banding. So it's pretty simple for every gastroenterologist to perform. And what we are doing in PEC-B is that we do the anti-reflux mucosal ablation, but with the help of EVL bands. So as on the lesser curvature side, we were ablating the mucosa, the same thing, we do it with EVL banding. We apply multiple EVL bands along the lesser curvature and at the G junction, thus causing inflammation, which heals by fibrosis and augments the lower esophageal sphincter. So here you can see we are applying bands initially in a retroflexed view along the lesser curvature of the stomach. We apply around 6 EVL bands. The total constriction length is somewhere around 5 centimeters. After applying these lesser curvature EVL bands, we get our, this is in the retroverted view, and then we make our scope in forward viewing position, and we try to apply 4 to 5 bands at the G junction. Thus, the end picture looks like this. This is the G junction. This we have just started applying EVL bands. This is after the application of the lesser curvature bands, and then we apply some bands in forward viewing position. So we are doing the same thing that we were doing in anti-reflux mucosal ablation. Those procedures, the problem was that they require general anesthesia. Patient requires to be intubated. The procedure, there are multiple intra-procedural complications. There's a lot of bleeding. It's all mucosa. You are removing the mucosa, so bleeding is there. Sometimes there are small perforation which also needs to be managed endoscopically. So these are the studies which we reviewed. They were small studies only. Most of them, two were retrospective, one was prospective. You can see the technical success everywhere was 100%. And if you look at the efficacy wise, 70% efficacy. It's as good as any other endoscopic intervention, GERD-X or TIF, but it's very simple. But then there is no study after that. No one is really trying. So we thought, let's go ahead with PEC-B therapy and let's give it a trial. How does it really work? Because there's definitely good data available. So in this patient, we did PEC-B therapy and there was a marked improvement in quality of life. And at 9 months follow-up, she's currently completely off PPI, which she was taking for the last 1.5 years. We also went ahead and we did a prospective observational study to assess the efficacy of PEC-B in patients with persistent GERD. We included the same, the general criteria for any endoscopic therapy, that patients who are having chronic GERD, no normal esophageal motility, and no or small hiatus hernia they should be having. Large hiatus hernia, we have discussed that surgical techniques are the go-to choice. Our primary outcome was again the same for any endoscopic therapy. The primary outcome is improvement in symptoms. That is improvement in GERD health-related quality of life. But we also went ahead and did some secondary assessments to objectively assess the decrease in reflux. We did endoscopy to look at resolution of esophagitis. We did pH study to document decrease in acid exposure time and Demister score. And finally, the third outcome was to assess how many patients were actually off PPI at the end of 3 months. So we recruited 80 patients, screened 80 patients for inclusion in the study, of which around 40 patients were finally included to undergo PEC-B therapy, and all these patients were assessed at 3 months for primary and secondary outcomes. Majority of the patients were young patients, around 36 years of age. Around 6 patients were having endoscopic esophagitis. So at the end of 3 months, there was a significant decrease in symptoms related to GERD, with more than 50% having more than 50% improvement in GERD health-related quality of life, which is the standard outcome for assessment of any endoscopic therapy for GERD. If we talk about secondary outcomes, the objective evidence of decrease in the acid exposure, there was a decrease in the acid exposure time as well as the D-Meester score. All the patients who were having esophagitis at the beginning of before the therapy had a resolution of esophagitis, and at the end of 3 months, 87% patients around had some symptomatic improvement, with more than 50% patients who were off PPI at the end of 3 months, who were earlier taking prolonged PPI, at least more than 6 months of PPI. There was one case of perforation in the initial of our procedures, but which was managed with laparoscopic surgery, and fundoplication was done at the same time. All the other patients just had mild chest pain post procedure, which required oral analgesics for 1 to 2 days. So if you compare all the other available therapies, the cost of PECB would be possibly less than 5,000 if we include the procedure charges. Also, the procedure time is only 10 to 20 minutes. The learning curve is very short, just 3 to 5 procedures. Everyone has applied EVL bands. Everyone is very well versed with application of EVL bands. It's the only procedure which can be actually done on outpatient basis. And the only major complication that the patients have is some pain after procedure, and which resolves in 1 to 2 days. So to conclude, GRD endoscopic treatments are providing the gap between the medical and classical surgical treatments. They are generally safe, well tolerated, and minimally invasive. Learning procedure, although is sometimes difficult for most of these procedures, and a lot of these are tech driven. However, PECB, it's a non-invasive, it's a non-tech dependent, very cheap and very effective, promising therapy for endoscopic management of GRD, and further studies are, long-term studies are, however, needed. And possibly the way ahead would be combined therapies, where you do some endoscopic therapy, there's no improvement, patient can go ahead with surgery. That problem is also, I think we are still evaluating this therapy, that we are not causing any harm to the lower esophageal sphincter. Even if 50% of your patients improve with PECB, it's a very good results. The other 50% can still undergo surgery because you have not caused any harm to the G junction at this point of time. Next would be obviously a sham controlled RCT, which is our next plan to definitely see what is the efficacy when we compare it to a sham controlled procedure. Thank you. Now we can take some questions, I think.